As you know, I mostly contact and cooperate with the heads of medical institutions and with medical community. I will speak about the needs that exist now in this sphere, as I see that many healthcare managers and healthcare workers listen to us today. I will speak in Russian language since there are some viewers here, including Peter Ross, who understand Russian a little. When we talk about the needs that primarily have to be met by the electronic healthcare system, eHealth, not ESOZ, because it performs practically the financing function. After all, we are talking about priorities for patients and for medical workers. Therefore, I will speak in a simple language as a layman about what I read. I'm an administrator of all kinds of Facebook groups, so I read a lot of information there. In fact, there is a video on Comedy Club which portrays a very important meeting. Sometimes I come across the skeptics and sarcasm that all we say and do is either far away from what is needed now, or it looks like this very important meeting where you just have to decide to stick or to nail. Now I will tell you what this is about. My morning started up today at 5:02 with a search for a place to hospitalize the patient. Now, how long will it last? At the other end of the handset, the operator of Primarily Healthcare told me that to call is my job. Let me apologize for these expressions after such words. He and the crew have finally come but demanded that I call the administrator and give them confirmation. Hospitalized with the struggle. That is, a primary care doctor calls all medical institutions in a row to find out if there are any free beds for COVID-19 treatment, even for emergency, to come and take the patient. She indicated the specific time of the call. Then comes the question. Isn't it impossible to create a call center that would reflect the status of free beds in the region, where to transport the patient and so on? We see that here is 392 likes and 120 comments, which I'm not going to share. Dnipro. Today, my family doctor tried to hospitalize his colleague from another medical institution with COVID-19, which was complicated. The coordination lasted from 9 a.m. to 16 p.m., and this is the medical worker attempted to fit in. He was rejected even by his native hospital. As of 19 p.m., our colleague was in line in hospitalization in the reception room. Then there are accusations towards the Ministry of Health of Ukraine. Hello, Ministry of Health. Pay attention that your relatives do not waste time even looking for a place where they will be buried. This is a fresh post from October 21 with the coverage of 25,000. You can imagine what a scale it is. There are 266 likes and 209 people shared it in less than a week. Unfortunately, we have the same situation. In my opinion, this issue is not complicated, but no one wants to solve it. Is it really impossible for the management of these institutions to display the number of free beds for each branch at the end of each working day, leave the data to the next doctor in the row, and pass it on to the emergency to help dispatchers hospitalize and so on? If you wish, you can read more. We don't have to look for a place, that's for sure. Every chief doctor of secondary care setting of infectious disease departments should submit to the department the data on free beds. If the real data is hidden, then provide the electronic list of places in hospitals. It would be great. The overall number of places, the number of patients, the rest is clear. I will not read all the comments. In fact, people die because of lack of assistance provided in time, because of not being hospitalized. They start calling and trying to get the heads of departments to confirm that it is possible to hospitalize the patient. I read all of this having some relation to the flow of data, which is collected in huge numbers from people who work there. They come and ask, do I have to glue or to nail? And you just talk about strategy, about the concept and architecture, but they have the needs right now. In fact, here in comments, people are dying because no help has been provided to them in time. I go to the National Health Service of Ukraine website, in this case, and I understand that there is an indicator on the dashboard, the bed's occupancy for treatment COVID-19. From a different perspective, I understand that this data is monthly old approximately because it is collected on the basis of reports handed in by medical institutions on COVID-19 from time to time. I certainly next text the NHSU employer. We have a very good constructive relationship. The answer confirms the following. The data put on the dashboard is of the past period. It depends on the discipline on how accurate and promptly this data was put. Therefore, there may have been a certain delay last month. Last week, this screenshot contained August, the month is now September. Thus, the next fact is that ESOZ, not eHealth, does not collect information about free beds. It is collected only in reports on medical services that are handed in to NHSU once a month at the end of the reporting period. Therefore, there is practically no option to track this online, but there is such option in the special site of Cabinet of Ministers of Ukraine. I'm a meticulous person, so I go to this website and ask whether it is possible, if the process of data entry begins, to still track at least such things. I would like to emphasize that this has nothing to do with the patient's personal or medical data. It's just a number of free beds that are needed to understand and to have a cross-control, meaning there is no possibility to decline. It is cross-control in terms of possible manipulations with this data, with free beds and occupied ones. So I go to the website I was told to. There is a dashboard which collects a lot of information, including COVID-19 data. I have to spend some time to rummage around. There is a panel for the average loading of hospitals. If you click on one of the regions on the map at the bottom, you will see only the average hospital workload of the entire region. There is also a pop-up indicator. How many of them are free, how many are for infectious diseases, how many are for temporary intensive care, and so on. Then I think that this data has to be taken from somewhere, someone fills it in. I ask a question, there is collected data, but where to look for something more? It has to be based on some tables, when the average indicator for each data is shown, the amount of intensive, non-intensive, and so on. And again, they prompt me that there are Excel files which can be downloaded and looked through. There you can see some data. I return to the Cabinet of Ministers of Ukraine website, and indeed, there exist these files at the bottom, and it is also written that they are updated almost every 2 hours. I start to find out who collects this data. It is collected by medical units or something related to it. I called the responsible employee who said that they should in principle be filled in daily up to 4 p.m. This is not always the case, but they are still filled in. Then the data arrives at the cabinet, and the cabinet uploads it here in the dashboard. You have to understand that medical institutions collect and transmit a huge amount of information, and there exists statistics. This is how it is pointed out here. Let's start with the main metadata, directly at the Ministry of Healthcare, then table of regional value National Security and Defense Council, means of individual protection, submission of 3 tables of online, the track of the patients in each hospital, the amount of medicine, and so on. Then the chat continues. Same 7 tables each morning and all until 9 a.m. We will soon go crazy. Thus, all the data you have seen are filled on a separate website, metadata.com.ua. Accordingly, there is an instruction. Once there was a request sent, I cannot tell you now according to what order or instruction it was made. You have to enter metadata by following the link and enter the data on your institution. This has to be done until 15:30. The responsible person sits down in front of a computer every day. This is how the quantity of fields look like. There are a few such lists to be filled. All data has to be filled in daily till 15:30 in each establishment. I can now show you how the table actually looks like. There are 78 columns. This is the table which you can download. There are different columns, including personnel who work on COVID-19 and everything you need. It is all collected to find out the level of equipment, means of individual protection, and so on. It is collected on a daily basis, and by the end of each day, all data must be transmitted. However, I want to add that in addition to the data that is transmitted to the NHSU, there are employers who have to fill them in here. What all of it brings us to? I want to show you here among these 78 positions, there are a few fields which in fact interest me, only 5 of them. There is the total amount of beds allocated for hospitalization, the number of infectious one among them, the occupied infections, the intensive care, occupied by resuscitation and intensive care, and the overall amount occupied by COVID-19 patients. By subtracting the last column from the first one, it is at least possible to understand how many beds are free. On this basis, the chart is made on the dashboard, which shows only the percent of overall occupation in the region. Here comes a very simple question. When we talk about the information environment that is being created and has to be created, and the fact that eHealth should be of particular benefit to patients and medical workers, a huge number of people waste their time and nerves. I don't know for sure how reliable this data is. This is also a big question. They fill in these tables every day, but to benefit from this data that is transmitted in such a huge amount is impossible. You see the consequences. This is conflicts, this is patients' deaths, and so on. The question is, why and for whom the electronic healthcare system was created? If the data is collected in any quantity, it should be immediately used. Therefore, I have a logical question. From time to time, someone tries to accuse the Ministry of Healthcare of this. In the comment I've shown to you, the Deputy Minister Irina Mikachuk writes, I forward the greetings and gratitude for a good transition of patients to medical administration of Dnipro area. Thus, we understand that regional healthcare leaders have certain obligations and responsibilities. To fulfill this obligation of providing healthcare for the inhabitants of the region, they need tools, they need this data. Respectively, all data is transferred to NHSU in terms of payment. And there is no need for NHSU to collect this information daily for payment purposes, although it is still received. Thus, there is no need to share this information. The priorities are different, and the goals too. This is not ESOZ obligation. From a different point of view, Cabinet of Ministers needs this data, therefore it is collected completely parallel. A regular employee, a doctor, a chief doctor, or even the head of the region cannot have easy access to them. These tables are not in Excel, but in CSV format, meaning I have to open it in a proper way. And then the question arises, when we talk about what and for whom we are doing all of this in the first place, there are needs right now and they have to be realized. If the structure and eHealth system are built in the way that it cannot provide quickly what is needed for those who use the system, it means that something went wrong. Something has to be done about it, and it has to be fixed. I just want to ask a question, an almost rhetorical one. I see it on examples from other countries. How in the Netherlands the system works under COVID-19, how in Kazakhstan it is done. We had a presentation last time, they showed the Denumed system that in 4 weeks deployed a system where you can see literally everything. All the ones hospitalized, an interactive mode. You can see where, how, who, what type is hospitalized, in what conditions they're in. In Ukraine, we cannot record it and give the opportunity to medical staff, doctors, chief doctors, heads of regions, see at least the real and true quantity of free beds instead of picking up the phone and calling everyone. If we continue building the same centralized system, either ESOZ or eHealth or another central database, we have to understand that it is necessary to set a technical task for all medical information systems. Somehow they must add this parameter, this additional functionality. It has to be tested, has to be transferred to the central component. Only then it will be available to all medical information systems and doctors who use it and implement this functionality. I assume that even from the formulation of the problem, it can take a month or a month and a half. I can be wrong, of course, but I think that is approximately the case. The priority task is for whom and for what we are doing this. During the spread of COVID-19, we implemented medical resorts on the birth of a child in the ESOZ system and integrated it with other registries. This is good and right. However, there are needs that have to be satisfied because these are the things eHealth is developed and used for. In this regard, I would like our further development, including the electronic healthcare system, meet the needs of regions. The Deputy Prime Minister of Healthcare, in fact, directly declared that this is the region's task. Regions have needs, meaning regional information system can and should develop regardless of how fast the central component develops, how quickly it aims to do that, regardless of the database owner's priorities. Hospitalization takes place at the regional level and people live in this territory. To organize the transfer of data, this exchange by the number of free dates, at least within one region and one system, is logical. It will benefit patients and doctors right away. Therefore, it is being considered right now in terms of the concept working group within the framework of the digital model. I want these priorities to be set only in this way, with the goal and objectives for patients and doctors in the first place. And I want these tasks to be monitored. Besides, I want the architecture to allow to all providers to do this quickly and flexibly and to respond to the needs that patients and doctors currently have.